No, thanks very much. First, for the organization of this LatinX. I think that when I was younger, I didn't realize how important it was to create community and to see the people. So thank you. I know that there is a lot of work. So, and thanks a lot to the person that thought that about me being a keynote. Thank you. And before starting, I also wanted to say that I am 6 months pregnant. So probably it's the last big conference that I can go for a while. And many times people talk about diversity and inclusion. And many times you need a person in mind to think for what we want to have childcare or for what we need this person in order to go to a conference in less than 2 years. Maybe she needs to bring someone to carry the baby. So keep that in mind. And also that this is the first ACL conference that occurs below Rio Grande. And for me, it was very, very spectacular because I had to walk every 30 minutes in the plane. And imagine a flight 12 hours. So I was very lucky that Santiago, Ciudad de Mexico was like 8 hours and was a direct flight. And I couldn't go to ACL that pregnant. So that small things, sometimes you don't, if you are not a woman or if you are not in the fertile or you don't want to have kids, sometimes you don't see that the small things that you need to make it happen in order for you to keep doing research. So thank you very much. And I know that maybe you came for clinical NLP, and I'm going to talk about that, but I'm going to talk a bunch of things. So I'm chronometerizing myself because I want to throw a lot of stuff that we are doing. But first of all, I need to make this happen. Artificial intelligence in medicine has these kind of flavors. I haven't worked on that. That is the worst scenario. And really, when I give this talk to people from medicine, they are like, of course, it's so clear what it says there. And of course, there is multimodality that is it's getting very famous and is super cool. But in clinical NLP, the things that my group has done why is different to study Twitter, I don't know, social networks. Unstructured information, when you go to a doctor and they or other health professional, they take notes of what happened. What happened to you, like the anamnesis, and also if you need a prescription for something. And that's all free text. There is a lot of abbreviations. And I don't know if you remember when you had to take a lot of notes. Now in computer science, we don't do that much. But I remember being at school trying to make como principalmente, and the mente you put like a symbol, to don't write the mente because it's too long. Well, medical doctors do that a lot. The health professionals, and it's not that they have a dictionary in the site, like I'm going to abbreviate this thing. No, they do whatever. And there is typing errors. Imagine the urgency. Like it's not that you are not writing a paper, you are writing something that is happening in the moment. And we believe that there is information that supports decision-making. And in the past, like many people in medical informatics, they were using just the numerics, just the categorical variables, and the text was like behind. Of course, now NLP is famous and everybody wants to do large language models and things like that. So it's getting like a lot, the use of secondary data more common, but for a while it wasn't. There is a lack of resources for languages other than English. I don't have to tell you enough of that. And that's why my group and myself, we work only in Spanish. And something that I will talk, and also, I didn't have a slide on that, so I have to say it by word. We have a Birds of Feather with Luciana Benotti and Guido on Monday at 4 p.m. to talk about privacy issues. And you may say, well, it's important in every time, the privacy, but in medicine, it's a human right, the privacy. So we cannot just think that it's a cool thing, no. So classical tasks in natural language processing applied to medicine can be the detection of key information. That is the task that actually I do the most. And that is, for example, in a paragraph, recognize where is a drug or like a medication or disease being mentioned, the automatic coding that is not just recognize that there is a disease, but assign a code for the International Coding of Diseases, for example, or GRD. I mean, there are many ways that you can do. But it's very interesting to do that because ICD is international. It's done by the World Health Organization. So hypertension and hypertension, they have the same code. So you can use the ontology for a translation high quality of terms. Text classification, and that's something that I will talk. This HES is if referral is prioritized or not according to the Chilean government. But of course, you can text classify many things. And something that I'm going to talk is about the anonymization because I care about privacy. And if you are new to clinical NLP and you want to start from somewhere, Hercules Dalianis from Sweden wrote that book. He was last year in Chile. He's super open to collaborate, so you can talk to him. And also this paper that is clinical NLP in languages other than English. And also Aureline Obol, she has been many times in ACL. But I wanted to point out that this paper, there are 2 people from France, 2 from Sweden, 1 from the UK. And we have been talking about that with Aurelie, how the title is very bold, languages other than English. But we agree that at the end, it's a very narrow vision because there are no people from Asia in this paper, or there is no Latin American representation. So I think that, at some moment we were thinking about writing the second part of this paper, getting more people involved and like what is going on now in clinical NLP. It hasn't been done. I don't know if we will do it any time, but maybe some of you will take that pressure. And I was very glad that some people knew about this. So I'm going to talk about our Chilean waiting list corpus. Why is important? Because it took 2 years during the pandemic years that we were annotating 10,000 referrals. And that paper also was Best Paper Award in the clinical workshop in 2020, and was the first time that me and my group went to an ACL conference. And it was so easy, so cheap, because it was pandemic times. So I have been a big advocate. I love to be here. I love that you are here too. But we know that we are very privileged to be able to travel and to get grants. So that's why it's very into my heart, this corpus, because it was a lot of work, but also because it got so good recognition that gave us the support that we wanted and we needed to keep doing the work. So why it's called waiting list is because in Chile, you have to go to a primary care physician to get an appointment to see a specialist. That happened in the UK too. The problem is that the waiting time in Chile, the median waiting time is 432 days to see for first time a specialist. Like you wake up, you feel that you have something in your heart, you go, you get in a waiting list for cardiology, and that takes more than a year. There are things that are prioritized. Of course, we are not that bad. We will be all dead if that will be the situation for everyone. But this happens in the public healthcare system. The private is a totally different thing. Like, I'm not proud of saying this, but I'm in the private, I'm pregnant. I don't know, like I need to get things quickly. And the thing is, if you have money in Chile, you go to the specialist, the cardiologist that has a PhD in whatever, you can have that. But I care about the 75% left that don't have that. And we started, I did my postdoc in Johns Hopkins, and we got a grant to study the waiting list in Chile. And after, 6 months, we realized that it was all about NLP, because the suspicion or like the reason for referral was written in free text. And when we were in Hopkins from the US, thinking about the stuff going on in South America, we were thinking like, let's do machine learning for prioritization. And then we realized that all the information, the key information was written in free text. So it's much harder to prioritize people. So, and as the presentation said, I am a physicist. So I was doing equations and a bit of computation in my PhD in Cambridge. And then I moved to the US and started doing public health. And I didn't really wanted to move to another time. I mean, I was already trying to make a career in something, but this problem is so touching to your heart, and it's so important that we realize, okay, let's do NLP. I mean, not we. I mean, at the beginning was I. The people in the US didn't do it with me, but then I met Fabian Villene, that is here, that is my PhD student, I mean, my half PhD student, and we have been working 8 years together on this problem. And this was the thesis of Fabian, actually the master thesis in medical informatics that was about prioritizing, like that was 2019, war embeddings times. And we worked with a hospital for 7 months, just trying to make sure that the people that had the opportunity to be prioritized, I cannot say prioritize really well, but you understand, prioridad, priorizar. That the people that had that priority could get that priority. And we wrote a paper. And actually in the Mexican summer school, we were talking a lot about where we Latin Americans publish, and it's because our universities don't recognize ACL conferences as a venue for promotion of things. So for a while, we wrote only papers in journals. So this is an example of a journal paper that we wrote about NLP use for a hospital. And then the Chilean waiting list came. We started to collect, and I was talking with some Mexicans colleagues, that how we could share a corpus that was real, was written by primary care physicians. It was because the waiting list is a public document in Chile. I will say it again. It's not that the consultation is public. Like what happened in the box, I mean, when you are with the medical doctor, is private, and it goes in the, I don't know, in the software that they are using. But then when you are referred to a bigger hospital, that goes in an Excel, that is the same Excel for the whole country. And then they have to write why you are in that waiting list. And that text is public. And as a Chilean, I can request that text. I didn't know that. I was very lucky to know that. But from 2018, we got 11 million referrals in that way. For a year, that's what's mostly what we did, writing emails to hospitals and health services saying, we want to do NLP, oh no, we want to support this problem, but we need the text. And we were very lucky, and we got 11 million texts of those. And 10,000 of those were annotated. And thanks to that, we wrote a bunch of papers. And I put the link of the presentation in the chat. Anyone that wants this presentation, please reach to me or the organizers, because I mean, that's the idea, that you know that we're doing these things, and we are openly share the annotated guidelines and the corpus for everything. The idea is that it's not as hard for us to start as it will be for you. And that's how it looks, the Chilean waiting list. Should I put disappear? No. Okay. Eventually it will go out, away or no? So this is an example of a real text being annotated. And if you see, for example, this is very nice. G0P0A0 means zero gestación, like it hasn't been pregnant, it hasn't had a delivery of a baby, and also 0 abortion. It's all written in 6 characters, And also we were very careful in annotating relations as well. So for example, here's an ecography that is being abbreviated. And then there is the result of an ecography, that in this case is a ecogenic, I mean, they found a tumor, and they are saying the size of the tumor. So this is what we did. And also our corpus is 41% dental, because Fabian is a dentist, and also because we started to, I mean, when you have one dentist and then other dentists came. So at the end, we had many people to annotate dental. And if for medicine in Spanish, there are few resources, for dental in Spanish, there are 0 resources. So we are very proud that we did that too. And that's, those are all the entities that we annotate, and we also have attributes that are the negation and pending, because it's a waiting list. So if something was saying something like an ecography being, the person is waiting for an ecography, we had to put ecography as an exam and also pending. And as I said, that we also have relations, and this corpus is open in Zenodo. And we also went a bit further, and we did the automatic coding nationwide. That means for 25 million referrals, we helped the government to annotate everything with the International Classification of Diseases. And that was done by Fabian et al. And that went to the clinical workshop in ACL. And in the Mexican school, we were talking about how sometimes there is not a match between the impact that you are doing maybe in your community and how fancy is that paper for main conference. Well, you see, like we keep publishing in the clinical workshop like crazy because that's mostly the place that we get accepted. And also we work on the transcription. Michael, also another dentist, and he worked in his master thesis on recording himself as a dentist himself, saying referrals, and then we were in a paper that is under review. We checked different commercial platforms for transcription, and then we apply our model that is name entity recognition to have like a summary. And if you see, this is a platform that you can say copy and paste, and the idea is that the medical doctors can say, or dentists, they can say what's going on, and later it will be easier to just copy in the healthcare records. I knew there was something wrong. Okay, so that's the Chilean waiting list. I hope that you are a fan, as we are, of the thing. And we have also worked on oncological text. In particular, we were interested in recognizing morphology and topography of cancer in Spanish. We collaborate with the Barcelona Supercomputing Center because they had a Cantemis that was a shared task. And what we did in Chile was to add the topography. And actually, there was a question like, how different is Spanish from Latin America, or within Latin America with text from Europe? And we found out that at least for cancer research, it's very similar. Like we in this paper that is under review, we check like what happened if the model was trained with people from with text from Spain and tested in Spanish or in Chilean Spanish and so on. And we found out that the difference in accuracy of the model was very low. Like you could say that there were, it's a very it's high-level specialist text. So we believe that there's no much difference. So you could use it in other countries in Latin America too. And also we did this, that was the automatic detection of metastases in reports in Spanish, again, which was published this year in JCO. And again, the corpus is annotated, is free, the annotation guidelines, everything. And this is how it looks. Like M0 means M0 means no metastasis, and M1 is that there is a metastasis. So that was the problem of Ricardo Humada that he wanted to solve. And I know that I'm passing like quickly because I have so many things to say. So and occupational health is something else that we have been doing. And it was motivated by this paper by Claudio. Claudio is my other PhD student that will come also. And he has this problem of a language model trained for detecting if someone was covered or not has a health, like a work-related accident. And that paper was 1 billion words, real clinical words, okay? And here I have to say I mentioned that if you talk to people in Europe, for example, the Barcelona Supercomputing Center, that they do a lot of things, usually they have to publish, they have to work with papers, like clinical trials or medical papers about a disease that is not the same to be in the box writing text. I don't know if you noticed the difference, but as a medical doctor writing a paper later in your home and submitting to a journal is not the same like being in a box writing and typing things. So we were super excited about, and we claim that this paper is the biggest corpus of real clinical text being published, okay? It didn't go to the main conference, but we were writing this sentence that motivates a lot of our work now, is this, that within this data, we know it's possible to find personal and sensitive information. The anonymization process was not carried out, and memorization can occur. So we cannot share the corpus, you know? And that motivates our work in privacy, because we thought, like, we cannot keep doing this. Like we did all that stuff, but we cannot share it. So we cannot publish in some venues because we cannot have that double check by you. So this year, we have in the clinical NLP workshop this Friday, this paper that is a new corpus, that is privacy preserving corpus for occupational health. And again, we have everything in Zenodo. And here we had this collaboration with the the Chilean Safety Association, ACH, and we explained them that there were some processes that you could do. You could de-identify the text, and that was important to improve NLP in Spanish, whatever, and they believe us. So that corpus was manually annotated to remove sensitive information. And the final thing that I do in work-related accidents is that, thanks to a grant for feminist artificial intelligence, we were able to check gender differences in work-related accidents. And I just want to say, for example, the purple is females and orange males. And we found out that the females, like, they fall como caídas, like far more than men, for example. So that's a paper that we are writing right now. And I'm also interested in high temperatures and accidents. Eso. Okay, we have 8 minutes left. So that's clinical NLP. On Friday, we will be available, and we are available every day. So please reach us. But the new research line that I'm working on is the Chilean dictatorship. And why it's important? Because there is something called the transitional justice, that when societies, it's not just that some people got hurt, it's like the whole society got prosecuted, or not the whole, but like a big part of the society got prosecuted by the state, is something very different and very serious. And how do you go out of that? It's called transitional justice. That includes getting the information, trying to find the people, trying to make memory of those, and also no repetition. So we wrote just this grant about starting from very bad images, and then you do OCR, and then you spell correction. I mean, you have to imagine that those documents are from the 70s, and the quality sometimes is not, it's not sometimes, it's most of the quality is very bad. And we want to do annotation of those corpus, name entity recognition, and then knowledge graphs. So this is something that people have been doing in Latin America, and there is, I think, a big chance of having a collaboration that we need. So what's the motivation? There is a lack of transdisciplinary work in the analysis of archives. In general, of course, people from social sciences and humanities, they have been working on those documents, but not computer science that much, and not from the perspective of name entity recognition and things like that. And there is a national research search plan that has not considered the academia yet, so we want to work anyway. We have a team of computer vision, NLP, and knowledge graphs, and also we have a human rights lawyer, a historian, linguist, and we have the support of 4 civil society institutions. And countries have, I mean, Latin America, during the 70s, many countries have dictatorships. In particular, for example, there is something called the Plan Condor that included 5 countries, Uruguay, Paraguay, Bolivia, Argentina, and Chile. That was a way to prosecute people across those 5 countries. So I think the collaboration is ready to go. And for example, annotation guidelines. And finally, KIPU, that is a conference, I have a slide about that. KIPU will happen in March 2025 in a country I cannot say. And it will be a special session on dictatorships. And I mean, we always can use the conference to have a satellite conference about these documents, and that's my idea. And I want to use my time to say about in the Mexican summer school, we were talking about what can we do from the South? And in the panel, I said, I think that we can also talk or like give an example of how can we create data sets in a fair way. And in that panel, we were also talking about how, I mean, it's not so easy as paying very few for annotating a lot of data, and then the people get a fancy paper. That's not fair. I mean, no one lives from the money that they receive by annotating. So I wanted to make sure that you know about this data set that is CVQA. You can download the paper. And what is nice about this work is that everybody that worked annotating images, I mean, we have to pass some threshold of 100 per person. We were authors in the paper that now is being checked by in NeurIPS. So we didn't get paid in money, we got paid in authorship. And this is the data set. For example, these 2 papers, there is one here in the room. Guido is in the photograph. And the idea was to have question and answers that were easy or that they were possible for someone from the culture. But as researchers, we also had to create alternatives from the correct answer that they were like good enough. Like someone from outside could like, for example, in that case, that instrument for what it is for moving brasas. I don't know how to say, like well, it's written there, embers, or for cutting the meat, or for putting the embers in the floor, So it's very nice. This paper is now in archive, and actually, if you go to the link, it will be the archive because it's being reviewed in NeurIPS right now. And now I want to say about science communication, and I have a podcast that is called Ciencia de Datos in Spanish. And it's very important for me because I have been able to have the podcast that I would have liked to listen. I have, I don't know, like I have a attentional deficit a bit. And when it's very formal, the talk, or I don't know, high level, I get bored. So I try to make it very funny. And I have had a bunch of topics. First of all, they didn't. At the university, I teach the course of data science for healthcare. So my first interviews were very medicine focused, like what is to be a radiologist? That was like with a radiologist, and we were talking how data science was changing radiology and things like that. But then I started to work on, well, there is Tamar Solorio, there is Luciana Benotti that will come next month. So I have been putting like people from abroad too, and I have been writing or at least podcasting episodes that those are called bonus because are things that I just want to talk about. So for example, I talk about productivity. I even went that far to talk about menstrual cycle. And then I had a series of like videos. Well, And right now there is this one about memory and data science. So for example, that's the Chilean episode that came last week. And this Wednesday, it comes every Wednesday. It's about Uruguay and then Mexico and then Argentina. All about the dictatorships, we have a special issue. And if you see me any day in this conference, it's a big chance that I'm going with my microphones in the backpack. So we just need to find a place, any place. I mean, we can go in a corner and talk for 40 minutes and you can be in the podcast. And also I have been making book clubs. In particular, Data Feminism was translated by Data Género in Argentina, and we read it in Chile, and now we are reading The Invisible Woman. And I wanted to point out this, like this is my open Instagram, and that, for example, 27 June, that is like after NAACL, is online. Like we always do, I mean, we do a small session in person, but then the next day is always online. And now we have more and more people from outside Chile. So if you are interested in like, oh, maybe I want to participate in a cool book club, go ahead. And this is Kipu. Tomorrow, they will start the advertisement of 2025, and it will, when it says follow us, usually it's Twitter, but from tomorrow there will be an Instagram account as well. And for 5 days, the people from communications will start saying, where is Kipu next year? Where is Kipu? So the people, I don't know, the idea is that there will be some small ideas of what it is. So please be sure that you follow. And also, as Luciana said in the Mexican summer school, there is a mailing list, and she tries to put, I mean, and many people tries to put opportunities for Latin Americans. So the idea of Kipu, I'm sorry, I should have said that, is to bring a top-level conference in artificial intelligence to Latin America, and there the speakers pay to go, but the students don't. And it's even further. Like we don't get registration fees, but also we pay the hotel and the flights for the students, and we can accept 350 people, 400 people. So it's amazing, and I'm very proud to be part of the organization of Kipu. So thanks very much.
Thank you, Jocelyn. We have some minutes for any questions.
So for the waiting list corpus, is there any human annotated prioritization available and or final disposition of what happened to the patient?
So humans did the annotation, but I didn't get the second part of it.
Do you know what happened to the patient finally? Were they sane after 2 years or?
No, we that has been hard to kind of follow up the project, because it was done mostly in the pandemic time. So for a while we were, okay, let's annotate, let's write papers. But then after the pandemic, we were like, okay, now is the time to go to the government and talk to them. And then we did this paper with them about the annotation, the coding of the whole country. But it has been hard to get them really deploying our system and taking decisions with that. And in particular, it was a bit bad that the ChatGPT storm made look very easy to do NLP for some people. So we found out that some hospitals or some people were putting in ChatGPT the things and asking them to code. So that's our problem now. And then I mean, you can try to get a project going, but at some moment you get tired. So we started getting very good results with work-related accidents. So we thought, like, let's go a bit in that direction. But yeah, no, it's not being used nationwide.
I'll take it. You were talking in one of the slides about privacy and the efforts that you took to follow standards by the Chilean government. And I was wondering if you achieved 100% privacy by manually annotating, or if there was a percentage that was set forth that you say up to this, we feel certain that it's private,
Mhm.
or there was 100% guarantee that
Yeah.
it's not.
No. So for that, we work. Tomás Vakili is a student in Sweden that works with Hercules Dalianis, and they have this corpus and like years of de-identifying things, and in particular, like they work more than crossing out or like masking private information. What they do is to pseudonymization, that is like putting another name. Like every time that you find a name, you put another name. Every time that you find an address, you try to put another address, because they say you can never put 100%. You cannot put your hands on fire that if you did automatic name entity recognition for recognize sensitive information, you cannot really know if it was 100%. So that's how the people in the literature say, like, that's what we will do. But in particular, in this privacy corpus, we had 3 people checking for private information, but it was like 3,000 documents only. If you want to do massive detection of sensitive information, that's something different. And I think that if we do at some moment that, we will do the pseudo-anonymization, that is like switching for names, because, and I think that some people like mimic data set, they put like a claim, like, by the way, sign this that you will not try to find who are in the data set. I mean, sometimes the people do that, like we know that is not perfect, and you have to sign this, saying that you will not try to identify people.